So congenital nasolacrimal duct obstruction is something that all oculoplastic surgeons and general ophthalmologists as well as pediatric ophthalmologists encounter. So I'll be giving a stepwise pattern of how to diagnose and treat this condition. So the lacrimal system, as we know, includes everything, right? From the tear secretion in the lacrimal gland to the conjunctival cul-de-sac, the puncta, the canaliculi, the nasolacrimal duct, and then the valve of Hassner where it opens into the nose. And an obstruction at any of the levels of the drainage system can lead to epiphora in adults as well as in children. In children, however, this is typically seen at the lower end, which is the opening of the nasolacrimal duct under the inferior turbinate, because typically what happens is there is an incomplete canalization where there is a membrane at the opening over the valve of Hassner. Now, 95% of children who are born with a membrane at the valve of Hassner, this condition resolves by the first month of life. And in the 5% in whom this hasn't resolved by the first month of life, 96% of those 5% resolve by the end of 1 year spontaneously, which actually leaves a very small subset of patients in whom we actually see the CNLDO presenting to us even beyond a years of age. And which is why this age of 1 year is very crucial for us. How does it present? It can present to us in multiple ways. I can see in the top left, there is crusting over the eyelashes. Top right, there is a dacryocystocele. There is a mass presenting with a bluish hue. There could be a lacrimal fistula in the middle left. The middle right is acute dacryocystitis, as is the bottom left, which is evolving into orbital cellulitis. In rare cases, causes of congenital epiphora can also show a fistula through which it is draining, tears are draining. There can be other conditions that mimic CNLDO, like supernumerary puncta or punctal agenesis, which is why, as Dr. Sumit mentioned, a detailed history and evaluation is extremely important before coming to a diagnosis. Now, in adults, as was demonstrated beautifully how you should do a syringing, it is easy to come up with a diagnosis because syringing can be done in the outpatient in adults. But in children, it's not that easy because children are obviously not that cooperative, which is why the signs are far more important to look out for matted lashes, crusting that we saw in the previous picture, and rhoplast or regurgitation over pressure over the lacrimal sac area. Pressing over the lacrimal sac area, you can see regurgitation from the puncta into the conjunctival cul-de-sac. And finally, FDDT, which is fluorescein dye disappearance test. If you see the bottom photograph, this is FDDT, which is we will put in a drop of paracaine, stain the conjunctival tears or the cornea with fluorescein, and allow the patient to normally blink for up to 3 to 5 minutes. Now, typically at the end of 2 minutes and at the end of 5 minutes, you should see partial clearance and complete clearance of fluorescein. And in patients who have a delayed FDDT, even at 3 or 5 minutes, you know that there is probably an obstruction in the drainage of the tears. So what is standard textbook teaching that we keep learning about is that any child who presents to us with congenital nasolacrimal duct obstruction, the treatment of choice is lacrimal sac massage. Now, this is where I have an issue because this is not a massage that we are doing. What we are doing is compression, and there's this wonderful editorial written because this is a massage and this is not what we are doing. We are doing compression. And this editorial in the JPOS was extremely well in highlighting that once you say massage, it conveys a different meaning to the parents and they do what a massage is to them. So, like say, for example, this gentleman who was described by their ophthalmologist how to do it, and they have been doing lacrimal sac compressions for about 3 months, and I asked him to demonstrate what he was doing. And you can see this kind of a lacrimal sac compression is absolutely pointless. He's massaging the side of his nose. So we need to demonstrate what it is, how it is done, how lacrimal sac compressions are done. The point and the purpose of this lacrimal sac compression is to press over the lacrimal sac area such that the intracystic or the pressure within the sac, the hydrostatic pressure, increases such that there is a give way at the lower end or the valve of Hasner and the membrane gives way. This is the aim behind lacrimal sac compression. So what I prefer to do is to demonstrate it on the parent or the attendant who is accompanying the child. Do it on the child in front of them. Do it on the parent or the person who's a mother who is accompanying the child. And then there is a WhatsApp clip that we record of me doing it on the child and send it to the parent. Ask them to watch this each time that they do it for the first few days. Obviously, it has to be done 10 times a day, each repetition being done 4 times throughout the day. So by doing this and demonstrating how it is being done, it helps. And this is a clip that Dr. Swati Singh had come up with, which is extremely useful in demonstrating what needs to be done. It shows the area to be pressed, it shows the finger, and it also shows the direction in which the compression has to be done. You need to occlude the common canalicular opening while you compress on the lacrimal sac. And this demonstration with the animation really helps in getting parents to understand what it is that we need to do. And we've seen that compliance and outcomes have improved since the demonstration is better. So simply telling that this treatment has to be done doesn't help. And what after 1 year is over? We can see that the spontaneous resolution probability by the time the child exceeds 1 year is 0%. So we see children beyond the age of 1 year still being advised to conservative management with compression. That doesn't work. In these cases, probing has to be done. My cutoff is 12 months. It is done under anesthesia with endoscopic guidance. And the reason why endoscopic guidance is that CNLDO is not always simple CNLDO. These are complex variants of CNLDO where you have a buried probe, you have a bony obstruction, you have incomplete canalization or aberrant opening into the septum, etc. So you need into the lateral wall, etc. So you need to be very, very clear of what you're dealing with. A simple putting an endoscope, the purpose of putting an endoscope is to be able to visualize with certainty that the probe that you've put in through the canaliculus, through the punctum and the canaliculus, is visualized under the inferior turbinate. Now that is the inferior turbinate. That is where the opening of the nasolacrimal duct should be. And you can see that there is a metal probe coming. Metal to metal contact or direct visualization is sufficient. Very rarely you can have cases where you have congenital dacryoseals or dacryocystoseals. This is an imperforate membrane at the level of valve of Hasner and a functional block at the level of the common canaliculus. So what do you need to do in these cases? You need to make sure to rule out an intranasal cyst, which is something that accompanies a lot of patients with dacryocystoseals. So the best way to treat this condition is to perform a cruciate marsupialization. The reason being that you can see that the entire nasal passage is blocked by this. So especially in children with who are being breastfed, on the contralateral side, the mother's breast is compressing the other side of the nostril and the intranasal cyst is compressing this side of the nostril, so the child can have respiratory distress. Cruciate incisions are made. The purulent material through the intranasal cyst and the dacryocele is drained out. This is a single incision, but then you need to use a crescent knife or a sickle blade and create a cruciate incision such that the 4 leaflets spread apart as healing goes on. And this can help you in going from this to this, and the early probing in these cases is advisable. Conservative compression in dacryocystoseals is not preferred. You would rather probe early. So in children who have never been probed, I am inclined to give a trial of probing up to 8 years. Between 8 to 5 years, I advise the parents that I will do a trial of probing, but these cases tend to be complex NLDO with either an imperforate canalization, incomplete canalization, or bony block, or a deviated nasolacrimal duct opening. So these cases, a trial of probing is offered, but on table, if we feel a DCR is needed, then a DCR is done. Children with CNLDO who have come presented beyond the age of 8, I prefer to directly go in for a DCR. The reason why the cutoff of DCR is 5 years is that it is believed the sinus pneumatization occurs and is completed up to 90% by the age of 5. So pediatric DCRs, like I mentioned, stent is placed in most of my patients. I prefer to use mitomycin C. An endoscopic route can be preferred, although for pediatric DCRs, I'm still more inclined towards the external route. One small thing that I'd like to comment on is the recent advancements in balloon dacryoplasty. So this is preferred in CNLDO obstructions which have failed previously, or in syndromic associations. Literature suggests multiple rates of success. Now, what is done is that you initially dilate the punctum, and you have what is called a lacricath, which is similar to an angioplasty balloon. You introduce it down till the metallic stent is visualized at the end of the turbinate. So you're at the same time doing a probing as well. Once you visualize it, then it is inflated up to 8 atmospheric pressure for 90 seconds. And once it is kept inflated for 90 seconds, it is deflated. Again, it is the same process is repeated, where you slowly increase the pressure within the stent to 8 atmospheres, and then keep it come back. Following this, you pull it out a little till it is in the lacrimal sac, and again dilate it. So to summarize, CNLDO is a common condition that can be conservatively managed till the age of 1 year with appropriate probing advice. 1 year is the threshold, appropriate conservative massage. 1 year is the threshold for probing. Up to 5 years, one can give a trial of probing. With endoscoping is recommended while probing. And following the age of 5 years, a DCR can be advised, and you have successful outcomes in these patients. Thank you.